talking about malnutrition in elderly, this topic today. I chose this topic because I thought it is more common and serious problem, which is mostly underdiagnosed and undertreated. We normally admit the patients with infections and hip fractures to the hospital. We treat them and we send them home, but we rarely recognize the problem of malnutrition. So my goals and objectives for today are to appreciate the scope of nutritional assessment and intervention in medical care of elderly, to know some definitions, prevalence, significance, causes, and some symptoms of malnutrition, and also to understand different screening tools for assessment and management of malnutrition. And last but not least, coding is also an important in evaluation and treatment of this malnutrition. So I'm going to start with a case, 82-year-old female with a history of hypertension, coronary artery disease, renal failure, osteoarthritis, living alone with a fixed income in some mobile home, and dependent on friends for the transportation and all. Came to the clinic with the problem of dressing herself secondary to her left shoulder pain, and we noted that she has about 10 pounds of weight loss in last 6 months. So what do we do? So what is the definition? Protein energy malnutrition is as per the Annals of Long-Term Care. It defines as a deficiency of total calories and protein, which is manifested by decreased anthropometric indices, depleted visceral protein stores, and depressed immunity. It also, the malnutrition in whole, it also includes different macronutrients and micronutrients. The recommended macronutrients are water. We need to take at least 8 ounces of water 8 times a day, which is calculated like 30 ml per kilogram per day, or 1 ml per kilocalorie, whatever you eat. And if carbohydrate should constitute at least 55 to 60% of your total calories per day, and out of which at least half of them should be carbohydrates from whole grains. And the recommended proteins are actually 1 to 1.5 grams. Before it used to be 0.8 to 1, but recently it says 1 to 1.5 grams per kilogram per day. And during stress periods, it has to be a little bit more than that, about 2 to 3 grams per kilogram per day. And fat should constitute at least 30% of your total calories. Cholesterol 300 milligrams per day, and fiber at least 4 grams per day, and different electrolytes and different micronutrients like vitamins, like B12 is most important one, other cofactors, minerals, trace elements, calcium, phosphorus, iron, and also the vitamin D is also more important than the micronutrients. So what are, according to the National Health and Nutrition Associations, the energy needs are estimated on basis of your weight. They say 25 to 30 kilocalories per kilogram body weight per day. And for obese patients, you have to use their ideal body weight. You should not calculate according to their real body weight. And protein needs are estimated on the basis of weight too. So 0.8 to 1.5 grams per kilogram per body weight per day. And the same, you should use the ideal body weight for obese patients. And whenever there is infection or stress, or if patients are very much malnutrition, we should increase the protein content. And basal metabolic rate is very important. That is the mainstay of estimation. And we use this Harris-Benedict equation to estimate the basal energy expenditure. And these are the formulas which are very long. I don't know how much they're useful. We also look at this anthropometrics. Anthropometrics are the non-invasive measurements of to help you to estimate or evaluate the nutritional status of a patient. Clinically, if patient loses 10 pounds of weight in 6 months, or if patient is less than 100 pounds, then they have relative risk of death of 2.0 and 0.99 for a positive predictive value of malnutrition. And according to the minimum data set, this is another screening tool that usually used in nursing homes. According to the Omnibus OBRA Budget Reconciliation Act, they come up with the definition that weight loss, if you take the weight loss into consideration as an indication, it should be at least 5 pounds or equal to or more than 5 pounds or 5% for 1 month, or 10 pounds or 10% for past 6 months. It is very much important in the nursing homes. They do this minimum data set assessments when you admit the patients to the nursing home, because it is also illegal for them to keep an eye on those measurements, so that you are keeping an eye on the nutrition of that patient. They do it periodically, taking all the information from the charts of the patients. BMI, body mass index, is also important measure here. As you know, weight in kilograms by height in square meters. And they say 18.4 or lesser has a greater risk of malnutrition, and if it is more than 30, it is highly related with increased risk with diabetes, hypertension, coronary artery disease. And according to the Obesity Educative Initiative Expert Panel, they describe this underweight if the BMI is less than 18.5, and normal weight they consider as 18.5 to 24.9, and overweight 25 to 29.9. It is more than 30, the obesity more than 40, it is extreme obesity. And other anthropometric measures they consider as skin fold thickness. They measure the skin fold thickness in the triceps in males and females both, and mid-arm circumference and calf circumference. And according to the studies, calf circumference has more sensitivity than other measurements. And what is the prevalence of malnutrition? In community dwelling elders, it is 15%, and there is increased risk of hip fractures and decreased activities of daily living. And in the patients we almost see in our outpatient population. And in hospitalized, they say it is 50%, but it is recently it says 50 to 75%. Actually, it is increasing. Nursing home residents is 40%. 10% of residents lose 5% of their body weight in 1 month following admission to nursing home facility, according to some studies. And point prevalence, they estimate it as 54%. That is from that particular source. And what is the significance of malnutrition? There are lots of studies. These are randomized controlled trials as published in journals of gerontology. The first one is a cross-sectional study. They studied in 311 patients in 3 nursing homes, and they followed their BMIs and their quality of life. They followed it for 6 months, and they figured out that low BMI with the protein energy malnutrition, they have negative influence in their quality of life. And another cross-sectional study, they studied about, this is a larger study, they studied 3,955 patients in 354 nursing homes in 10 states of USA. And patients were more than 65 years, and they followed their BMIs and activity of daily living, and they followed up for 6 months, and they came to the conclusion and published as the ADL loss is directly proportional to the low BMI, or vice versa. And patients losing 5%, they have 4 times high risk of dying within 1 year. And if they have 10% weight loss in first 6 months, they even have more, higher risk of dying in 6 months, despite or regardless of their age, gender, and medical problems. And the likelihood of death within 6 months for patients who continue to lose weight is 30%, and who are stabilized with their weight, 20% of people likelihood of dying within the next 6 months. Even though they started gaining weight, even then they have 10% of likelihood of death in six months. So our patient went home, during the first visit. As we said, we did not pay more attention for her malnutrition. So she went home and falls and breaks her left hip. Admitted to the hospital, underwent total hip replacement. So she developed pyelonephritis, bacteremia, and to the hospital, and she's delirious now, and she loses 15 pounds of weight. So what are the consequences, of not treating the malnutrition? So as our patient, she has, decreased in her functional ability. She developed, fatigue. She might have developed osteoporosis, which increase the risk of falls and hip fractures, and increase, susceptibility for systemic infections because of the suppressed immunity. And there is delay in wound healing, or it can also cause development of pressure ulcers. Ultimately, it increases the mortality and leads to death. If you identify this problem earlier, and if you prevent these hospitalizations, you will have, help with the healthcare costs. And there are some legal issues also, because you did not identify and treat, and patient ended up in the hospital. So that is also put you in trouble. So what are the causes for malnutrition? Physiological and pathological. As humans age, the gustatory papillae, they go down, they get atrophied, and you cannot taste as good as when you are young. And the olfactory epithelium also gets atrophied. They say that the olfactory epithelium, the signals and emotional feelings, they are processed in the same place in the brain. So they say if you add some flavors to some foods, it will stimulate your emotion and can help you increase in food intake, like different flavors. And physiological causes, like physical causes, people with movement disorders or strokes, and they can have problems with feeding themselves, shopping them for the groceries and food items. They will have problems cooking and preparing food, so that can also lead to decreased food intake and malnutrition. And diseases like diabetes, chronic renal failure, they have fatigue and decreased appetite, which can lead to decreased food intake. And also the food restrictions, like decreased salt, decreased fat, which will make the food less palatable, and they don't have the appetite to eat. And social causes, when they are living alone, they don't have anybody to share with. If they have social isolation, or any depression because of death in the family or friends, that can also lead to decreased intake of the food. And definitely you also have to look for the medications. So what happens as you age? From the middle age, you'll have increase in fat mass, especially around the abdomen, and that will replace the muscle mass. So you will have net gain in the body weight, decreased inactivity, physical inactivity, and decreased BMR. That will continue at least until 70, and when you are more than 70, it again gets worse. Like carbohydrate intake goes down by 40%, your fat intake goes by 55%, and your lean body mass goes down by 40%. And you tend to lose adipose tissue, like you lose fat as well as muscle. And because of the decreased physical activity, you have less endorphins, and you'll have less try to drink more water, which is another cause for dehydration and anorexia and weight loss. So our patient, she was still delirious, not eating, so she received NG feedings, and she pulled it out. So they started her on parenteral nutrition. After 48 hours, she's dyspneic, hypoxic, and edematous. So what happened here is refeeding syndrome. This usually develops with parenteral, overzealous treatment with parenteral nutrition, but it can also occur with oral feeding. and worse with worse malnutrition. I'm sorry. You can reduce it by, if you start the replacement slowly and reach the goal slowly, then you can prevent this problem of refeeding syndrome. So now she recovers from bacteremia because you treated her refeeding syndrome. She's tolerating a little bit of, she recovered, and she's not able to tolerate the acute rehab because of her weakness and delirium, and she's not doing very good with PT/OT because of her CHF. Her diet was kind of restricted. She was on narcotics because of her pain. She's depressed, constipated, and she's now requiring 1% SS for ADLs, and she has no appetite. Remember, when she saw you first, she was totally independent of her ADLs. Now she's needing 1 to 2% for her ADL support. So different symptoms of malnutrition, anorexia, sarcopenia, cachexia, different syndromes. Anorexia is reduced appetite. Sarcopenia, this is age-related muscle mass loss. And cachexia is the muscle wasting related to the disease process, mostly the chronic inflammatory process. And obese sarcopenia, you have more fat than muscle because of the low physical activity. You keep on putting weight. You look obese and happy and healthy, but you might be having terribly protein malnutrition up there and the failure to thrive. So what are the causes of anorexia? They almost are the same, like impedance of the food, salt, sugar, social contact. As I said, in the nursing homes, they usually put patients together, 2 to 3 patients together, or they take them into the dining hall so that they can have a little bit of social interaction and can have some stimulation to eat. And feeding, some caregivers have do not give the patients with dementia who have a little bit of problem with swallowing and chewing. So you have to give them the time. You should identify that they have feeding problems. And familiarity, if patients are from home and you admit them to the hospital. I have a patient in ECTC. He was totally ADL independent. He developed a perforated duodenal ulcer. They did a surgery, and he is in the ECTC rehab. But he stopped eating by himself because he's kind of totally new. He's with the dementia, but family did not identify the dementia. Now he's with a different environment and he doesn't want to eat. He always needs the cues for him to eat and swallow. So you have to pay attention for the familiarity. And the drugs like, phenothiazines, multiple drugs like psychotic drugs like SSRIs, digoxin, NSAIDs mostly, which are most commonly used, they all have side effects of anorexia. The hormones like ghrelin, they are appetite stimulants, so they are low levels in, as you age humans, the ghrelin goes down, which will kind of cause the anorexia. And other substances like nitric oxide, cholecystokinin, leptin is another hormone that is very much essential for fat intake and fat metabolism in muscle. As I said, ghrelin, growth hormones, or insulin-like growth factors, and testosterone. They say that testosterone has a linear, longitudinal decrease with the age. So testosterone is also more important for stimulation of appetite. The nitric oxide, which is present mostly in the smooth muscles, also present in the antrum of the stomach wall. So as you age, the nitric oxide goes down and decreases the adaptive relaxation. It will kind of makes you feel full early satiety, which is another cause of anorexia. Coming to the pathological causes, like as I said, depression. If you're depressed as such, you don't feel like eating. And the dementia, because of this apraxia and forgetfulness, they don't eat, they don't have an appetite. And you also have to look about their dentition, like if they're, problem with the tooth. or edentulous if they are wearing dentures. Many medications, especially anticholinergics, they kind of cause dry mouth and cause different feeling, and they cannot swallow the food. Dysphagia with the strokes and Parkinson's, they have problems swallowing, and many of the restrictive diets because of different disease processes can also cause decreased appetite or anorexia. And as I mentioned, many drugs can cause anorexia. Sarcopenia is another syndrome of nutrition. They say 2 standard deviations decline in the muscle mass when you compare to the young adults. Especially this is disuse atrophy because of the decreased physical activity. You stop using your muscles and eventually they get disused and replaced by fat mostly. It can lead to disability and mortality. You can check their sarcopenia by simply checking their grip strength. So even though you're a muscular man, you lose the muscle and replace by fat can make you all the tissues and muscle and replaced by gray fat. So cachexia is another syndrome. We call it back condition. Usually the wasting, muscle wasting and fat mass wasting associated mostly with cancers and severe chronic diseases in most AIDS patients in their late stages. It is a chronic inflammatory process. Many studies they show that cytokines are mostly involved in this chronic inflammatory process leading to cachexia, especially with the geriatric cytokine they call interleukin-6 or the geriatric cytokine, which are very high levels when you see patients with pressure ulcers, morbidity and mortality. So this is little just a representation of the macrophage releasing these interleukins and tumor necrosis factors causing inflammation. Cachexia and starvation are 2 different things. The appetite is kind of suppressed in the early phase of cachexia, but in starvation, it is during the late phase. The early phase of starvation, you feel more hungry and you're waiting for somebody to give you food. Cachexia is involved with chronic inflammatory process, but there is no inflammatory process involved with starvation. Since it is inflammatory process, CRP is levels are high in cachexia. The cholesterol are low in cachexia, and starvation it might be normal. Lymphocytes, even though you treat, there is no response, but with the starvation, there is response with the treatment. And same with the feeding. If you feed starvation, you can treat the starvation, but cachexia cannot. So how do you diagnose malnutrition? There is no single standard, gold standard study. So you have to do, history and physical is very important here. As my patient, first when she came, she's living alone, she's dependent on people for transportation. She was totally independent of ADLs, but you had to, find about any other symptoms like fatigue and decrease in ADLs. How the economical condition situation, she just only have a limited income, and you have to find out if she can afford for the food, because the people with multiple diseases, they have to buy so many medications, so probably they cannot afford for enough of food. Their functional status, if they are able to go shop for themselves, or if they can cook or prepare meals, and the emotional status, if they are depressed or if they're feeling isolated. Cognitive function, definitely, they don't remember if they eat, or even if they are eating, even if somebody is feeding them, you have to cue them multiple times. And they also have to assess the eating habits. When I'm doing the home care visits, I went to a patient, we figured out that patient is losing weight, we did not know what is happening, because she's been having multiple admissions to the hospital with the chronic abdominal pain. Whenever she's coming to the hospital, she's feeling better, and whenever she's going back, she's having again the abdominal pain. So we went there and we figured out, what are all the, stuff she has. She mentioned that her refrigerator is making much noise, so before she goes to bed, she turns it off, and whenever she wakes up, she turns it on. So the food is kind of, spoiled, and she's eating that food and she's getting that abdominal pain. So you have to sometimes dig deep into the eating habits. So what are the laboratory evaluations? There is no single ideal measurement. The albumin is not a very specific or sensitive indicator, but definitely the albumin, if it is less than 3.2, you have to raise the flag to work out a little bit. And 0.35 milligrams for every decline of 0.35 milligrams in albumin, there is 24 to 56% of increase in likelihood of dying. And serum cholesterol, if it is less than 160, we think that, oh my God, this is great, but this is definitely a malnutrition, because that is a very useful building block of the cells. So you need at least some cholesterol for your energy. And the hemoglobin, with the B12 deficiencies, iron deficiencies, they will be low. So you have to check hemoglobin also. And the lymphocyte count. The pre-albumin, it has a very short half-life. It is very much useful to check in response for the treatment, so that you will know what you are treating. And further assessment, there are multiple screening tools. I have kept a couple of the MDS, MNA forms, if you can just pass them around. Most of them are questionnaires, which a professional time is not much necessary, but for some, like mini nutritional assessment, professionals have to do it about 15 to 20 minutes assessment of that. The instant nutritional assessment, which is very simple, you can just see. Mostly you do the labs. So if you see that lymphocyte count as the albumin and weight change, you can thereby just are assessing in a very simple manner quickly the patient is having some nutrition problems. The mini nutritional assessment, it has in a short form and long form. The short form has 6 points in it. It tests about general health and food habits. If the score is I think more than 3 or 4, then you can further go ahead and do the detailed form, 18-item questionnaire form. If it is less than that score, you don't have to. The 18-point questionnaire form, if it is more than 24 points, patient is well nourished, and the 17 to 23.5, patient is at risk, and if it is less than 17, definitely malnourished. And this is another screening tool called Determine Checklist. They check about four items of general health, 4 items of disease processes, and 2 items including social and economical issues. So how do you manage the malnutrition? So ease the dietary restrictions a little bit. You don't have to completely stop, you don't have to tell the patient to completely stop taking salt or sweet, or restrict the fluid management unless it is compulsory, clinically necessary, like patient is dying of exacerbation of congestive heart failure. Definitely you have to look into that, but ease the dietary restrictions a little bit. And supplements, like give some finger foods, encourage the family to get some foods which are familiar to the patient, so that they can increase their appetite and increase their intake a little bit. Look into the drugs, mostly patients are having polypharmacy, if they really need the drugs or not, and discontinue some of those. And supportive therapies, like caregivers giving more time for them to chew and swallow the food, you should not be rushing them to just finish your work. Culturally sensitive foods, like from people from different cultures eat different foods, and if you give some McDonald's or something for different people, maybe they do not like it. So family participation is very much important in this situations. Allow them some snacks or health shakes. I'm going to discuss a little bit about that in my further slides. So this is some representation or some colorful picture for the patients to kind of how to take some portions. The gold says that the grains. They say 1/2 of the carbohydrate should be a whole grains, and the vegetables, fruits, and oils, which is very minimal, and the milk and the meats, which are protein. So what are all the nutritional supplements? You can do oral supplements or tube feedings or TPNs. The oral supplements, usually they are 1 kilocalorie per ml. There are a lot of different supplements available. In our VA, only Ensure Plus and just some supplements with high nitrogen are available. Different varieties of Ensure is the Ensure Plus, Ensure High Protein, Ensure High Fiber, and in other facilities, other kinds of supplements like Boost with the high protein, high fiber, and Boost Plus. There are other preparations like Incarnations Instant Breakfast that is not available in VA, but outside HEB, in HEB or other grocery stores, it is available as Hill Country Instant Breakfast.
Doesn't the VA have some sort of similar product though?
No. Yeah, actually I spoke with a dietitian yesterday, and she said that she tells the patients to go for HEB. That's how I came to know that there is another brand of a Hill Country Instant Breakfast. There are some health shakes. If the patient is not lactose intolerant, you can offer some health shakes with different flavors, which can actually most of the patients like health shakes because they don't have that vitamins now, so mostly they prefer the health shakes. Special formulas if patients have diabetes or liver disease, different formulas, especially the Glucerna for diabetes and fiber source for other. The tube feedings, whenever a patient needs emergent malnutrition therapy, if they're not eating, for temporary periods, you can use different types of non-oral feedings. All formulas, they have protein, calorie, fats, and water, as it mentioned, and different percentage of calories depending on the protein, fat. You have to be careful with the protein because it can cause dehydration. Patients with pancreatic problems, using hydrolyzed protein will be helpful. So what are the indications? Patients with the stroke or Parkinson's, severe Parkinson's, they are not able to eat at all. And if they have high demands, and post-op patients, especially if they are on ventilators, you can use nasogastric feeding. Sometimes you can also go for peg feedings, but that is very rare. Absolute contraindication is mechanical obstruction, like if they have fracture of their nose or mandible, maxilla, then you cannot do the tube feedings. And the complications, they say vomiting, So if the patient, you have to weigh the risks and benefits. Only, as I said, it is indicated only for temporary periods. So there is no nutritional benefits if the patients are, with advanced dementia or terminal illness. Actually has an increased risk of aspiration. Even though you feed them with a PEG tube or a GI tube, they still have that, the sphincter relaxation and constriction, so you still can regurgitate the feed and can get aspiration pneumonia. And it will be like a physical restraint because they have to have that tube in their nose or throat, and the pack tube, they have to carry it around. That is kind of restriction. And because of the aspiration pneumonias and mechanical problems, it can increase hospitalization and electrolyte abnormalities. So you should not offer the chew feeding as an option. You have to encourage every time for handheld feeding or oral feeding. And in spite of all this education, still that patients with advanced dementia, 1/3 of patients of advanced dementia are chew fed because mostly of the family involvement and family requests. So what are all the pharmacological interventions? There are multiple products available out there. Especially most commonly used is magistral acetate, metazapine, which is more commonly used in nursing homes nowadays, and other opioid derivatives, Ritalin, steroid products, cyproheptadine, but they all have lots of side effects. So I'm going to go over a little bit of this magistral acid, which is called Megase. Have to give at least 400 to 800 milligrams daily in divided doses for 12 weeks. And it takes about 3 months for to show any increase in weight or increase in appetite, but it improves the appetite and feeling of well-being and increased levels of energy. It can also, because it's a steroid product, it can affect the testosterone, decrease the levels of testosterone, which can lead to impotence and loss of libido. It can cause hyperprolactinemia. It can affect on estrogens and adrenal suppression because of its steroid activity. It can also lead to muscle loss, especially it affects the lower limb muscles, so it increases the risk of falls in elderly. It can cause delirium, edema. Because of its effect on estrogen, it can increase the risk of DVT than normal people, and blunt the beneficial effects of physical activity. So lots of studies done and showed that patients treating, one of the studies showing the median survival of 24 months, and other studies showing 31 months. On average, there is no difference in the weight after 6 months. So when you're when you're considering treating a patient with Megase, you have to think about it, because it actually increases all-cause mortality without a significant increase in the weight. So another product, testosterone, can be used to increase the muscle mass in patients with sarcopenia, because it decreases the destruction of muscle cells. Actually, it stimulates myocytes and stem cells, increase the muscle strength, increase the functional capacity. So multiple studies show there is a moderate increase in muscle strength in men, and more effective route is intramuscular. So you can consider treating the patient with testosterone, but mostly it has more positive effects in men than women, because it has a virilizing effect. That is one of the side effects, so you should think about when you're trying to treat a female patient. So physical exercise, actually, because of the increase in endorphins, can stimulate the appetite and intake, increase the muscle mass and strength, improves the memory and self-esteem, improves the depression because of the endorphins. It reduces the oxidative stress, and more useful in treatment of sarcopenia because it increases the muscle strength and muscle mass. For cardiac cachexia, beta blockers, because they decrease the resting energy expenditure and decrease the lipolysis. Those are helpful in cardiac cachexia, and as well as the ACE inhibitors. So these are all new medications still under trial. Anti-myostatin antibodies, melatonin, and SARMs, the steroid, some anabolic steroids, modulators. Those are still in the trials. And dihydroxyandrosterone is a new drug still coming, still the research is going on. We don't know really very much about. So as our patient hip fractures, sometimes protein repletion can help with this preventing hip fractures. Some of the polls, so is a clinical guide. So you can keep some protocols like weekly checking weights in a nursing home patient. Periodic checking on a nutritional status, functional status, and the skin condition, and use best evidence approach. Use this MDS, minimum data sites from nursing home records, patients' charts can help you identify the malnutrition problem. So my patient finally she recovered from delirium. They added metazapine for her depression, which improved her appetite and helped her with sleep. So we took off the anxiolytics. For constipation, we added Dopacate, some of this, ensure. Although it improved her weight a little bit, improved her functional status a little bit, but she was completely ADL independent before the admission, first admission, but now she continued to decline in her function and cognitive decline. So she didn't have any family members and she cannot go live by herself, so she ended up in nursing home. So some guidelines for malnutrition and long-term care. As I said, documenting weight loss and weekly weight monitoring, nurses checklist. We have quality indicators that we check monthly in the nursing homes. So in MDS, in minimum data set, they have these triggers and flags. They have to do it every 3 months. And the resident assessment plan is made according to the status, so that you can allow the patient to be in some parameters, and if that's how you can just pick the nutrition problem or weight loss, and you can treat the problem. And if you did not pick it up and if you did not treat the case, then especially with the Medicare and Medicare funded nursing homes, you'll get into trouble. So treat the irreversible causes, definitely. Reversible causes, but sometimes you have to consider the terminal illnesses, and you have to educate the family and document the advanced directives and palliative care patients, that feeding tubes are not very helpful. Actually, you have to educate the family members that they increase the risk and increase the mortality and morbidity, and they will not prolong the survival rate. So these are some of the ICD codes which are helpful in coding. Mostly we use 261 or 797 and 263.1. The conclusion, even though we kind of rarely observe this problem, it is more prevalent in the elderly, and you can use most of the screening tools to help you assess the nutrition problem, malnutrition, and early diagnosis and intervention prevent morbidity and mortality. And supplements definitely have help in the therapy. Some references. Thank you.
Thank you.
Anybody have any questions for Dr. Gampala?
There are some handouts.
There's some handouts, and we also have your eval sheet for it, and it's on both sides. Did everybody get one? Y'all can fill it out. Anybody that's new, if you could stay behind, that we could have another half an hour session. No, I'm kidding. I just need to